Then there is another thing, as the blood starts pooling now in the atria as well, there would be back pressure. The blood that has to come back from the lungs into the atria, that blood would have difficulty coming into the ventricle, into the left heart, because left heart is already congested, already filled. That would cause blood pressure in the pulmonary vessels to go up, and that would cause blood volume to go up in the pulmonary vessels. As the blood volume and pressure goes up, I'm going to make a pulmonary vessel here just to show you what does that mean. So artery brings in the blood. Let's make a capillary that is big enough here that we can see, and then the venule, right? Now we know that capillaries have gap junctions. There are cells in the capillaries, and then there are junctions between the capillaries through which the exchange of nutritional substances happen. As there is increased blood volume and pressure, what will happen is that the blood vessels would start becoming dilated and bigger under pressure. That would cause, so here is the important thing, oncotic pressure, which is the pressure of the fluid inside the vessel, oncotic pressure will increase. Hydrostatic pressure, why did I say oncotic? Hydrostatic pressure, which is the fluid pressure, oncotic is the protein pressure. Hydrostatic pressure inside the vessels would increase. That would cause blood or the fluids to start exuding from the junctions. It is like if you take a leaky pipe and there are puncture holes in the pipe and you increase the pressure on the pipe, those leaks would start jetting out. So this extra fluid that would come out will start accumulating in the lungs. Now how does that happen? This is important to understand. So I'm going to make an alveolus over here. Let's say this is an alveolus, and there is a capillary. I'm just going to make it red. You know that one end of the capillary is arterial and the other end is venous. So this is a capillary. Now what happens, as the blood starts pooling here, the pressure in the capillary goes up. That increased pressure would cause the exuding of the fluids out. So where will these fluids be going first? These will go in the interstitial tissue, interstitial spaces of the lung tissue. That means the person would start becoming breathless. Why? Because interstitial spaces are participant in the respiratory membrane, and now inside the respiratory membrane we have increased fluids. So we have reduced the efficiency of the respiratory membrane. That means gaseous exchange will become compromised. That means the person would start experiencing breathlessness or dyspnea. In the beginning, the patient would not find dyspnea at rest. What would happen is when the patient is exerting, when he is doing activity, exercise, he'll become more breathless than normal. Then when he's speaking, slowly this would progress. So when he's speaking, he'll become breathless. And then there would be a time, if this whole cycle is not stopped, there'll be a time that even at rest the patient is breathless. Then there will be a time that when the patient would lie down, we'll talk about it, orthopnea would happen. So now, first of all, interstitial transudate is present, edema is present. That would cause pericapillary J receptors to become triggered. These receptors are connected with the vagus nerve or vagi. So when they get irritated, when you try to inspire fully, what happens is that this rubbing and irritation of the J receptors would trigger the vagi, and vagi will block the inspiration. So patient cannot take a full inspiration, full inhalation. Then what would happen? Fluid would enter the alveoli. Then when the fluid would enter the alveoli and there is alveolar edema that would develop, then the patient would start coughing, and because of this extra pressure here in the vessels, what would happen is even erythrocytes will come out. Erythrocytes come out for two reasons. One, under pressure, the gap junctions have opened up enough that the erythrocytes can squeeze out. Second, there are going to be vessels that are bursting, vessels that are breaking, that are rupturing under the pressure. So the result of that is that there is bleeding. So there is both bleeding and then innocent exudation of the RBCs. The end result is that the macrophages that are sitting here in the alveoli, alveolar macrophages, these guys are going to engulf and eat these RBCs. Hemoglobin in the RBC is going to now convert into hemosiderin. Now when the patient has cough and sputum, that sputum, number one, will look rusty in color, and number two, if you take that under the microscope, you'll see heart failure cells. What does that mean? These are the macrophages that have eaten up the RBCs and they have hemosiderin in them. So you can see that. Now the patient's breathlessness has increased. This is the congestion in the lung. That is why this heart failure is called congestive heart failure. If this continues, then what would happen is that the lungs, where do they get the blood from? Lungs get the blood from the right heart. So that pressure wave will now start affecting the right heart from ejecting into the lungs, because lungs are engorged and they are thick and they are heavy and they are edematous. And you're trying to pump more blood. It's like a sponge that is filled with the water and you're trying to pour more water on it. So now the right ventricle would start undergoing stress. That would start failing the right heart. So the most common cause of the right heart failure is the left heart failure, which is causing the back pressure. So this congestion in the lungs would occur, then the right heart would start failing. If that does fail, then the right heart failure would appear as well. That's a separate lecture, we've done it. So this is the systolic dysfunction, etiology and the clinical parts of it. Of course, what does that mean? That means, if you see clinically a little more, costophrenic angles will become blurred because of the fluid accumulation in there. If you look at that in the chest x-ray, you'll see that the costophrenic angles have gone. Then the infiltration would appear, alveolar infiltration would appear on the chest x-ray. Peri-hilar congestion and upper lobe congestions would appear in the chest x-ray. Peri-hilar congestion is sometimes called the bat wing appearance. So you'll see the bat wing appearance on the chest x-ray. When you put the stethoscope on the patient's lungs, on the patient's chest, you would hear what? You would hear rales. Why? Because there is fluid accumulated there. You will hear crackles and crepitations. What is that? Because of the fluid that is present, and when the patient inhales, there are bubbles and these bubbles are breaking, and that gives you the crackles and creps. So these are the sounds that you would be seeing.